Hello again. Welcome to another lecture in Counseling 5480 Diagnosis and Treatment Planning. In this lecture, we're going to focus on bipolar and related disorders. In this chapter, there are three major disorders. Bipolar 1 disorder involves recurrent episodes of mania and typically depression. In order to obtain bipolar 1 diagnosis, there has to be at least one manic episode, and depressive episode is not necessary. Bipolar 2 disorder involves episodes of both hypomania and depression, and there is no presence of mania episode. Cyclothymic disorder characterized with similar symptoms of hypomania episode and depressive episode, but the symptoms are to a much lower extent and does not meet the full mania, hypomania, or depressive episode criteria. And another feature is that the symptoms need to last for at least 2 years. So in our daily life, we hear people saying bipolar, right? And we already know that they meant mood swings. And when we are seeing clients who are suffering from bipolar disorders, they often describe themselves as having emotional roller coaster. And this is a chart that's documenting or picturing that emotional roller coaster for you. As you can see, yes, their mood is everywhere, and that is really what drives people crazy. Have you watched the movie Silver Linings Playbook? If you haven't, I recommend you to pause the video right now and click on the link at the bottom of the slide to see a better demonstration of those bipolar symptoms displayed by this main character, played by Bradley Cooper. So the symptoms of bipolar disorder can be categorized into 4 groups. At this point, you're probably familiar with dysphoric, psychotic, and cognitive symptoms. So here, I'll just mainly talking about the manic mood and behavior. People with bipolar disorder may experience euphoria, meaning an intense happiness and excitement. And they may also feel that they are much superior to others in a very unrealistic way, which is called grandiosity. You may also notice that they talk really, really fast to the point they don't even breathe, and that is called pressured speech. They also display so many impulsive behaviors, and their sexual desire can feel like it's out of control. They tend to be reckless, socially intrusive, and when they're in a manic or hypomanic episode, they don't want to sleep. So there are essentially 3 different episodes in bipolar and related disorders. They are major depressive episode, manic episode, and hypomanic episode. And we just simply refer them as building blocks. Let's look at each of these episodes. And these are the criteria for a major depressive episode. When you read these, you probably realize that they are very familiar. And you're right, because these symptoms are identical to the ones that you've seen in the MDD. In a word, people need to have 5 out of those 9 symptoms in the same 2 weeks period. And at least one of the symptoms needs to be either a depressed mood or a loss of interest. According to DSM, a manic episode is a period of elevated, expansive, or irritable mood and increased goal-directed activity or energy for at least 7 days. In addition, they should have 3 of the following 7 symptoms. And if their mood is only irritable, they need to have 4 of these 7 symptoms. These are grandiosity, they don't want to sleep, they become very talkative and have pressure speech, They're thinking really, really fast to the point you can't really follow them. They can't focus very well. They can be easily distracted by anything around them. They usually have a very high motivation to do lots of different things. But the thing is, they will probably start a lot of those, but not able to finish all of them. They usually have poor judgment, such as they just go shopping and spend much more money than they wanted. They drive recklessly, so on and so forth. These symptoms are severely impacting their functioning, and the symptoms are not due to any substance use or other medical condition. The criteria for a hypomanic episode include the same symptoms as in the manic episode, but the duration is 4 consecutive days compared to 7 days in the manic episode. And then the symptoms are not severe enough to cause serious impairment in their daily functioning, but they are observable by others. And when the individual does not experience any of the symptoms, their function seems okay. Similarly, we also want to make sure the episode is not due to any substance use or another medication or medical condition. This chart is a comparison between a manic episode and a hypomanic episode. As you can tell, they both have the same symptoms, and they are differed in the duration of symptoms as well as the severity of the symptoms. Now let's look at individual bipolar disorder. Bipolar 1 has 2 criteria. Criteria A requires that the individual has at least one manic episode. Criteria B requires that the symptoms are not better accounted for any other psychotic disorders. Although most of the times people who has bipolar 1 disorder also experience major depressive episode, but that is not a necessity for you to put a bipolar 1 diagnosis. You can add a specifier when considering their current and most recent episodes, such as bipolar 1 disorder, current or most recent episode as manic, hypomanic, or depressed. When it comes to bipolar 1 disorder coding, your best friend is the table listed in the DSM-5 on page 126. You want to start with the actual disorder. In this case, we will record as the bipolar 1 disorder. And then you need to choose the type of current or most recent episode from one of these, either manic, hypomanic, or depressed. Then you start adding other specifiers such as the severity specifier, mild, moderate, severe, psychotic specifier with psychotic features, whether they are mood congruent or mood incongruent features, and the remission specifiers, choosing from between impartial or full remission. And then you compare to the table to see what is the accurate coding based on the disorder as well as the specifier you have. You could also add other specifiers without changing codes, including anxious distress, mixed features, rapid cycling, melancholic features, atypical features, and mood congruent or incongruent psychotic features, catatonia, peripartum onset, and seasonal pattern. The description of all these specifiers are very similar to the ones that we have already talked about in the major depressive disorder. Same as MDD, if psychotic features are present, then you use the code corresponding to that specifier rather than any of their severity specifiers. And this is an example diagnosis. F31.13, bipolar 1 disorder, comma, current or most recent episode manic, severe with rapid cycling. Bipolar 2 disorder has the following criteria. In order for someone to be considered as bipolar 2, they have to have at least one hypomanic episode and at least one depressive episode. And then they've never really had a manic episode in the past. Making sure the symptoms are not due to any other psychotic disorders, and the symptoms has caused clinically significant distress to the individual. Same as bipolar 1, you want to record the current and most recent episode to be either hypomanic or depressed. And then you can add as many specifiers as you want or as many as applicable to the client situation without changing the code. For bipolar 2 disorder, there's only one code, which is F31.81. Cyclothymic disorder is more of like a milder version of bipolar 2 disorder. People who suffer from this condition usually report having numerous periods of hypomanic or depressive symptoms, but they don't meet the full criteria for hypomanic or depressive episodes. For adults, they have to experience these symptoms for 2 years, and for children, the requirement is 1 year, and their symptoms are not absent for more than 2 months. There's only one specifier you can use here, which is if the client has anxious distress. With clients who suffer from depression and bipolar disorder, suicide prevention is of a paramount importance. Now, here are some facts about suicide. It is one of the leading causes of death in the US, and it's the second leading cause of death for younger people between age of 15 to 24 years old. Even though more women are committing suicide, more men than women actually died by suicide. Among people who suffer from bipolar disorders, approximately 19% of them ultimately end their life by suicide, which is really sad. And 20 to 60% of them actually attempted suicide at least once in their lifetime. Additionally, over half of the suicide incidents included a firearm, which is the most commonly used method for people who commit suicide. So what do we do? How can we prevent suicide? We can do so starting from a rigorous assessment process. During the initial session, we do the informed consent, and then we usually tell people about the exceptions of confidentiality. One of them is suicide and homicide situations. So in the following sessions, if you notice any signs of either suicide or homicide, we should follow up. In your intake session, making sure you have at least 1 or 2 questions regarding suicide. I usually just ask my client if they've ever had any attempt of harming themselves or ever thought about killing themselves. For a better assessment of suicide, I recommend you to use the SLAP method. If your client indicated to you some clues of suicidal ideation, I recommend you to use SLAP method. S stands for specific plan. You want to know whether or not they already have a plan, basically asking them if they know how, where, and when they would commit suicide. If they did have a plan, then you want to evaluate the lethality of that plan, basically asking yourself how deadly is the plan. The next letter A stands for availability of means or availability of weapons. If the client said that they want to shot themselves, do they have a gun? Do they have access to a gun? Do they maybe live in a house where their roommates or their parents have a gun? Do they have pills that they want to take in order to commit suicide. And the last one, P, it stands for proximity of help. How can they ask for help when they can't control their suicidality? Do they live with someone who can keep an eye on them? Do they have friends that they can call? Or do they at least have a number to suicide hotline? In counseling, we almost always use a safety plan. This is a template of a safety plan that you can choose to use with your clients who suffer from suicidal ideations. This is a time you can start a dialogue with them, talking about specific things they can do to keep themselves safe. And then at the end of the safety plan, you will make this as more of like a contract where both parties will put your signatures there. In that way, we can hold our clients accountable to this. I'd like to share a few risk factors for those who may commit suicide. Some demographic features include that the individuals are male, they're either single, widowed, divorced, or separated, or elderly people. Mental health wise, they usually suffer from mental disorders such as depression, schizophrenia, substance abuse, any sort of personality disorder, or anxiety disorders. People who have a high risk of suicide also include those who've already have come up with a specific plan for committing suicide. And if they have already attempted multiple times in the past, that's also a strong indicator. And then if they are isolating themselves, they live by themselves, or they are constantly rejected by others, those are all high risk factors. Other conditions may trigger suicide include physical illness, especially either life-threatening or chronic debilitating illness that has severely impacting their quality of life. The status of unemployed and retired is a risk factor. People who has a family history of mental illness, alcohol abuse, or suicidal history have a also high risk of suicide. And people who are suffer from bereavement or any kind of loss, they sometimes would say that they just want to live with their loved ones. Other factors include social classes at the extremes. Either they're so poor or they're so wealthy. The unstable family environment, including any kind of like domestic violence or any kind of abuse. And of course, trauma. So, what are some indications of people who may want to commit suicide? You would want to notice if they are starting to give away their possessions, or maybe they start organize their personal affairs. There may be some radical changes in their behaviors, the self-harm behavior, even though most people who harm themselves, they may or may not intend to commit suicide. They sometimes can harm themselves too much to the point where they just lose their life. The mood swings, such as the one featured in Bipolar, can be such a big warning sign. Can you think of any other warning signs? The rest of the slides I have provided a case study for you to review and start the diagnosing process. And we will process this study together in the next week. Because this study is kind of long compared to our other case studies, I recommend you to read ahead of time and take some notes so that you can be more productive in your breakout room exercise in class.